My presentation is on systolic left heart failure. The American Heart Association and the American College of Cardiology defines heart failure as a complex clinical syndrome that can result from any structural or functional cardiac disorder that impairs the ability of the ventricle to fill or eject blood. Systolic heart failure is defined as a clinical syndrome associated with congestive symptoms and/or symptoms of low cardiac output due to impaired ventricular pump function, or reduced EF. Left-sided heart failure is the heart's pumping action moves oxygen-rich blood as it travels from the lungs to the left atrium, then onto the left ventricle, which pumps it to the rest of the body. The left ventricle supplies most of the heart's pumping power, so it's larger than the other chambers and essential for normal function. In left-sided or left ventricular heart failure, the left side of the heart must work harder to pump the same amount of blood. There are two types of left-sided heart failure. Heart failure with reduced ejection fraction, known as HFrEF, also called systolic failure. The left ventricular loses its ability to contract normally. The heart can't pump with enough force to push enough blood into circulation. Impaired ventricular pump function in systolic heart failure is defined as an ejection fraction approximately less than 40%. Heart failure causes a decrease in cardiac output. This results from a decline in stroke volume that is due to systolic dysfunction, diastolic dysfunction, or a combination of the two. Briefly, systolic dysfunction results from a loss of intrinsic inotropy, most likely due to alterations in signal transduction mechanisms responsible for regulating inotropy. Global systolic dysfunction can also result from the loss of viable contracting muscle as occurs following acute myocardial infarction. Both systolic and diastolic dysfunction result in a higher ventricular and diastolic pressure. This serves as a compensatory mechanism by augmenting the force of contraction and therefore stroke volume by the Frank-Starling mechanism. This mechanism helps to maintain stroke volume. However, if the systolic and diastolic dysfunction becomes too severe, then the capacity of this mechanism to maintain stroke volume becomes exhausted and stroke volume can decline significantly. In some types of heart failure, the ventricle can dilate to very large volumes through remodeling as it attempts to maintain stroke volume and to limit the increase in end-diastolic pressure. The reduction in cardiac output associated with heart failure precipitates changes in systemic and pulmonary vascular function and renal function. These changes occur as a result of venous pooling of blood, reduced organ perfusion, and activation of neurohormonal compensatory mechanisms. Reduced ventricular stroke volume leads to venous pooling of blood, which elevates venous blood volume and pressure. For example, in left ventricular failure, left atrial and pulmonary venous pressures and volumes increases. This pulmonary congestion can lead to pulmonary edema and shortness of breath. Right ventricular failure, whether alone or as a consequence of left ventricular failure, causes blood volume to increase in systemic venous circulating, leading to elevated venous pressures and systemic edema. Reduced perfusion of the kidneys decreases sodium and water excretion, which in turn causes blood volume to increase. This further increases venous pressures. However, the increased blood volume serves as an important compensatory mechanism to increase cardiac preload, which helps to maintain stroke volume through the Frank-Starling mechanism. With systolic dysfunction, the Frank-Starling curve shifts down and to the right because of the loss of contractility. When this occurs, stroke volume is reduced and preload is increased secondarily. Compensatory increases in blood volume further increase preload and dilate the ventricle. Ventricular stroke volume can be improved by several routes: increasing preload, decreasing afterload, and increasing inotropy. In heart failure, preload is already elevated due to ventricular dilation and/or increased blood volume. Increasing the preload further will not necessarily increase stroke volume because a heart in failure is usually functioning on the flat depressed region of the Frank-Starling curve. In systolic heart failure, excitation-contraction coupling can be impaired at several different sites. First, there can be a decreased influx of calcium into the cell through L-type calcium channels, resulting from impaired signal transduction, which decreases subsequent calcium release by the SR. There can also be a decrease in TNC affinity for calcium, so that a given increase in calcium in the vicinity of the troponin complex has less of an activating effect on cardiac contraction. Natriuretic peptides are peptide hormones that are synthesized by the heart, brain, and other organs. The release of these peptides by the heart is stimulated by atrial and ventricular distension, as well as by neurohormonal stimuli, usually in response to heart failure. The main physiological actions of natriuretic peptides is to reduce atrial pressure by decreasing blood volume and systemic vascular resistance. Atrial natriuretic peptide is a 28 amino acid peptide that is synthesized, stored, and released by atriomyocytes in response to atrial distension, angiotensin II stimulation, endothelin, and sympathetic stimulation. Therefore, elevated levels of ANP are found during hypovolemic states, which occurs in heart failure. ANP is first synthesized and stored in cardiac myocytes as pre-PO-ANP, which is then cleaved to pro-ANP and finally to ANP. ANP is the biologically active peptide. A second natriuretic peptide, brain-type natriuretic peptide (BMP), is a 32 amino acid peptide that is synthesized largely by the ventricles, as well as in the brain where it is first identified. BNP is first synthesized as pre-pro-BNP, which is then cleaved to pro-BNP, and finally to BNP. Like ANP, BNP is released by the same mechanisms that release ANP, and it has similar physiological actions. Proteolysis of pro-BNP results in BNP and the N-terminal piece of pro-BNP. Both BNP and NT-proBNP are sensitive diagnostic markers for heart failure in patients. Systole is when the heart contracts and ejects blood to the body or lungs from the ventricles. When there is heart failure, the force of contraction, or inotropy, is decreased. This will lead to a reduced stroke volume and reduced cardiac output. This can all be due to a weakened heart muscle due to an underlying disease that causes cell death of the heart or cardiomyocytes. This will lead to thinner ventricle walls and enlarged chambers. Underlying diseases can be due to cardiomyopathies or heart muscle diseases. This will cause the heart muscles to weaken and unable to properly pump blood. Reduced blood supply of the heart due to coronary artery disease can also lead to left heart failure. We know that atherosclerosis can cause a buildup in the artery walls and lead to reduced supply of blood. In addition, during the inflammation, there is also apoptosis or cell death that can reduce the strength of the muscle even further. There can also be valve disease. When the valve becomes damaged, it can cause regurgitation, which will allow the valves to stay slightly open when they're supposed to be closed, which can cause the blood to flow backwards into the upper chambers. This will cause less blood to enter the body and flow backwards into the atrium. The heart will now work harder for it to maintain the same blood supply it had before. More work costs more oxygen demand, but with heart failure, it can't supply the proper amount of oxygen, which leads to more cardiomyocytes to die due to the lack of oxygen to those cells, which can cause weakened heart muscles. The heart of a person with heart failure may have a reduced force of contraction due to overloading of the ventricle. In a healthy heart, increased filling of the ventricle results in increased contraction force by the Frank-Starling law of the heart, and thus a rise in cardiac output. In heart failure, this mechanism fails as the ventricle is loaded with blood to the point where the heart muscle contraction becomes less efficient. This is due to reduced ability to cross-link actin and myosin filaments in overstretched heart muscle. Compensatory mechanisms in left heart failure: neurohormonal activation, Frank-Starling mechanism, and ventricular remodeling. Cardiac dysfunction causes drop in cardiac output. The fall in cardiac output leads to activation of several neurohormonal pathways. Although these neurohormonal pathways initially are compensatory and beneficial, eventually they are deleterious. This will lead to activation of sympathetic nervous system, renin-angiotensin-aldosterone system, and antidiuretic hormone or vasopressin. Sympathetic nervous system is one of the first responses to a decreased cardiac output. Increase in circulating catecholamines like norepinephrine, augmentation of ventricular contractility and heart rate, systemic and pulmonary vasoconstriction, stimulates secretion of renin from the kidney. Catecholamines aggravate ischemia, potentiate arrhythmias, promote cardiac remodeling, and are directly toxic to myocytes. Renin-angiotensin-aldosterone system is activated as a result of increased sympathetic stimulation and decreased renal perfusion. This will result in further arterial vasoconstriction, sodium and water retention, and release of aldosterone. Increased aldosterone levels lead to sodium and water retention, endothelial dysfunction, and organ fibrosis. Antidiuretic hormone, also known as vasopressin, is released from the hypothalamus, is triggered by low cardiac output, and additionally stimulated by angiotensin II. This will cause an increase of thirst, enhance water resorption by the kidneys, promotes water retention, and leads to a fall in plasma sodium concentration. Impaired cardiac performance can have a response of a salt and water retention, vasoconstriction, and sympathetic stimulation. This can lead to short-term and long-term effects, such as augments preload, maintains blood pressure for perfusion or vital organs, increases heart rate and ejection, or long-term effects such as pulmonary congestions, generalized swelling, exacerbates pump dysfunction, and increases cardiac output expenditure, and increases energy expenditure. Additional compensatory mechanisms include the Frank-Starling mechanism and ventricular remodeling. Within the Frank-Starling mechanisms, the ability of the heart to change its force of contraction and therefore stroke volume in response to changes in venous return. In heart failure, there is a compensatory increase in venous return, which is augmented by neurohormonal mechanisms. Due to increase in venous return, there is a temporary increase in stroke volume. Within ventricular remodeling, alterations in heart shape, size, structure, and function can happen. Ventricular dysfunction limits a patient's ability to perform the routine activities of daily living. Left ventricular remodeling can lead to things such as myocardial changes, necrosis, apoptosis, matrix of degradation. In addition, it can lead to mechanical disadvantages such as increased wall stress, afterload mismatch, increased oxygen utilization, and worsening hemodynamic overloading. In the left picture, we have heart failure with reduced ejection fraction, in which left ventricular remodeling is driven by progressive loss of cardiomyocytes. This loss of cardiomyocytes results from various modalities of cell death, such as exaggerated autophagy, apoptosis, or necrosis, all of which are triggered by oxidative stress present within the cardiomyocyte. The latter usually results from ischemia, infection, or toxicity. Excessive wall stress, because of cardiomyocyte loss, shifts the balance in the extracellular matrix between collagen deposition and degradation. These alterations within the extracellular matrix importantly contribute to left ventricular dilation and eccentric left ventricular remodeling. In heart failure with reduced ejection fraction, replacement of dead cardiomyocytes by collagen creates patchy areas of fibrosis. In advanced heart failure with reduced ejection fraction, seen on the right picture, systemic and coronary endothelial dysfunction is also present and attributed to increased plasma levels of TNF-alpha and interleukin-6. However, in contrast to heart failure with pronounced ejection fraction, the increased plasma levels of TNF-alpha and interleukin-6 do not result from pre-existing comorbidities, but are reactive to the severity of heart failure with reduced ejection fraction, as they relate to both New York Heart Association functional class and depression of left ventricular ejection fraction. Similar to heart failure with pronounced ejection fraction, endothelial dysfunction affects diastolic left ventricular function in advanced reduced ejection fraction. As evident from the relationship between diastolic left ventricular dysfunction and plasma levels of methylated L-arginine metabolites, which impair nitric oxide production by endothelial nitric oxide synthase. Patients with heart failure can present with a variety of signs and symptoms, such as fatigue, dyspnea on exertion, paroxysmal nocturnal dyspnea, orthopnea, jugular venous distension, rales, tachycardia, third or fourth heart sounds, hepatomegaly, and edema. The cardinal symptom of heart failure is shortness of breath, initially manifested when increased cardiac output is needed to provide oxygen to active muscles, as with exertion. As heart failure progresses, dyspnea occurs with less stress, as provoked by fluid shifts when recumbent, and in the final stages, shortness of breath is seen at rest. Physical examination during systolic heart failure will reveal an S3 heart sound if significant left ventricular dilation is present. In this case study, we have a 74-year-old woman admitted from home with progressive increases in breathlessness, orthopnea, and ankle edema over the previous 3 weeks. She has suffered from dyspepsia increasing over recent weeks, and the general practitioner had noted a new murmur. Sitting blood pressure was 110/70, and a pan-systolic murmur was audible, and late inspiratory crackles were heard throughout both lung fields. The EKG confirmed sinus tachycardia with 110 beats per minute, with anterolateral Q waves of previous infarction. Chest X-ray confirmed cardiomegaly and interstitial edema. Routine chemistry showed sodium of 129 millimoles, potassium of 5.8 millimoles, urea of 9 millimoles, creatine of 155 millimoles. A creatine kinase series was unremarkable. An echocardiograph showed a dilated heart, left ventricular and diastolic distension of 650 millimeters. There are two types of classification of heart failure: the American College of Cardiology Foundation, American Heart Association staging, and the New York Heart Association functional classification. According to the American College of Cardiology Foundation American Heart Association guidelines, all patients presenting with dyspnea should be evaluated for heart failure, and all should undergo a medical history, physical exam, lab testing, chest x-ray, and a 12-lead EKG. Recommended labs include a complete blood count, urinalysis, serum electrolytes with calcium and magnesium, blood urea nitrogen, serum creatine, glucose, fasting lipid profile, liver function test, and thyroid stimulating hormone. Chest x-ray can identify cardiomegaly, pulmonary congestion, and alternate causes of patient's symptoms. A two-dimensional echocardiogram with Doppler 2D echo is recommended to assess ventricular function, wall motion, and valve function. Measurement of brain natriuretic peptide or N-terminal pro-brain natriuretic peptide levels can support clinical decisions regarding diagnosis. Measurement of all biomarkers of myocardial injury or fibrosis should be considered. Biomarkers are useful in heart failure management as they may reflect pathophysiological changes indicative of heart failure. Biomarkers are any substance, structure, or process that can be measured in the body or its products and influence or predict the incidence of outcome or disease. 6 biomarkers reflecting renal dysfunction, endothelial dysfunction, and inflammation were associated with incident heart failure with reduced ejection fraction, including natriuretic peptides, UACR, CTN, cystatin C, D-dimer, and CRP. When directly compared, natriuretic peptides, high-sensitivity troponin, and CRP were more strongly associated with heart failure with reduced ejection fraction compared with heart failure with pronounced ejection fraction. Treatment for systolic heart failure includes angiotensin-converting enzyme inhibitors, which is an enzyme converting angiotensin 1 to angiotensin 2. Angiotensin 2 causes vasoconstriction, increasing afterload and thus increasing systemic blood pressure. Angiotensin contributes to the production of aldosterone, which normally acts to retain sodium and water. Reducing the activity of RAAS is crucial in heart failure, during which it is overactive and contributes to negative remodeling. ARBs, or angiotensin receptor blockers, are primarily used when a patient with systolic heart failure is unable to tolerate an ACE inhibitor, frequently due to a cough. Aldosterone antagonists are potassium-sparing diuretics which block the action of aldosterone, inhibiting the reuptake of sodium and water. Normally, when sodium reabsorbs, it is exchanged with potassium, which is then excreted. Because aldosterone inhibition decreases sodium reabsorption, it also decreases potassium excretion, resulting in higher serum potassium levels. Digoxin blocks the sodium-potassium ATPase pump, the mechanism by which this decreases atrioventricular conduction. Intracellular calcium within the cardiac myocytes is increased by digoxin, resulting in increased inotropy. Thus, digoxin is frequently used when atrial fibrillation and left ventricular systolic dysfunction coexist. The loop diuretics are utilized to help maintain euvolemia in patients with heart failure. These drugs are for symptom relief only and have never been shown to provide mortality benefit. Antidiuretic hormone antagonists helps to regulate water retention by absorbing water in the conducting ducts of the nephron. Blocking this receptor allows water to be excreted more readily. Many patients with heart failure present with some degree of hyponatremia from water retention. Nesritride is a recombinant form of B-type natriuretic peptide and is used for the treatment of acute decompensated heart failure. Nesritride has potent vasodilatory properties and reduces pulmonary capillary wedge pressure effectively. This results in improvement of dyspnea. Hydraxylene is a direct arterial vasodilator that decreases afterload. Isosorbide monotrite is a long-acting oral nitrate that decreases preload. The combination of these two drugs has an effect to that similar of an ACE inhibitor or ARB without reducing renal function or causing hypokalemia.